It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back and thanks for listening. I have a few announcements. The first is ASIP is coming in April the 4th to 6th, Dallas, Texas. It's going to be great. It's great every year. I highly encourage you guys to go. ASIP's probably one of the most political organizations. Lax is in charge. He's out there with the congressman trying to fight for us. So check out ASIP, support ASIP, and I think you'll have a good time. Hopefully you'll be in Dallas. If you're there, hit me up. I'll have a table at the event as well as I'll be at the meeting, and always love to chat. So look for me there. And the same goes for Aspen. Aspen's in July, and Aspen is an amazing conference. I really been going there pretty much every year, with the exception of maybe the 1 or 2 years during the pandemic. And a lot of great networking, great innovations in pain management, new devices, etc. So you're going to learn a lot from these conferences. And of course, I'll be running an ultrasound course at West Virginia SIP. So if you are in the vicinity of West Virginia or the Appalachian Spine and Pain Society, check us out. It's going to be a great ultrasound course. I have tapped a couple of instructors. Really excited about this. It's going to be a lot of fun. It's at a cool hotel called the Greenbrier, which most of you probably heard of. And it's on April 14th. It's a Sunday. It's a 2-hour ultrasound course. But if you sign up for that, you're also going to get online access to my 4 CME hour on-demand interventional pain ultrasound that you could do at your own pace. And you get that actually with any of my courses. If you sign up for any of my ultrasound courses, you will get access online to the on-demand component for an additional 4 CME credits. I also do private training and regenerative medicine training, which we do have a course coming up May 4th. And that's going to be in New York. You could Zoom it, or better if you could come be at the venue, because we do a demonstration of the PRP. And we discuss, of course, all the other biologics that may or may not be relevant to your practices. Once again, the board prep pain exam is on a new website called nrappain.org. You can still get there by going to painexam.com, but I shifted the platform to this more versatile, comprehensive, inclusive website that is going to just keep growing. And that being said, I am always looking for help. Volunteers, people who want to network with pain physicians, maybe get accepted to pain fellowship, and you need an excuse to talk to a program director. Well, helping me out on the pain platform or blogging, bringing relevant knowledge, summarizing studies, or just educating yourself and other people is a great way to get known, and a great excuse to talk to other pain doctors and hopefully contribute to the world of pain management, which is an amazing world, which, like I tell my patients, every year there's something new coming out. And speaking of that, I tried 2 years ago, and forgive me if I mentioned this on a previous podcast, I tried 2 years ago to use my cryoablation device, also known as iovera, to anesthetize or ablate the nerves of the PENG region, which is PENG stands for pericapsular nerve group, or hip lock. It was proposed by Giron et al., but this was led by Philip Peng in 2018 for treating perioperative pain in patients with hip fractures. Now, I've done this block in my office and as a chronic pain doctor, and I believe I have another podcast on this topic. And I've done the diagnostic block with lidocaine. Sometimes they add steroid, and I've even done cryoablation. And 2 years ago, I tried it, didn't work. Then my partner Gary Schwartz mentioned he does a lot of work with this, doing multiple lesions in this vicinity, and he had some success, and I recently started doing them, and I've also had some success. So there's a lot of cool things out there, and I researching the hip, I also had the idea of doing radiofrequency ablation of the articular branches of the femoral obturator nerve, which I have podcasts on. And I'll be honest, it's not as easy to do, or it's not. I don't find I have the same success as I do with the knee ablations. So in researching other options for the hip, I've done podcasts on viscosupplement as well as biologics, and anecdotally, I've definitely had some success. But hip replacement is actually a very good therapy for most patients when all else fails. But not everybody wants surgery. For the patient who doesn't want surgery, then these options that I'm mentioning are pretty good. Now, that being said, I was asked by ASIP to write guidelines for peripheral neuromodulation, peripheral nerve stimulation, and review the data for the knee, the shoulder, and the hip. First of all, the data looks good, but it's small. I'm just summarizing it. It's not like we have thousands of patients randomized controlled. I wish we did. We don't. And secondly, especially for the hip, I'm having a tough time. There's really not a lot out there, and it's a disappointment. But then again, that means there's room for many of us to perform studies, contribute, really get involved, and figure out if this is a valid therapy or not. And speaking of PNS, I'm doing a lot of it. I do quite a bit of sprint. I've done some of the PNS, and I'm going to be doing a chronic soon. So I think this is still in its infancy, and I think the technology is only going to get better, as well as the data is going to clarify. So just giving you a little bit of information about the hip. There is a case report by Emafu and Hesham El Sharkawi. Hesham I met, he's a great guy and does a lot of academic work. He's always at the conferences. Anyway, they have an interesting case report, which is a 67-year-old female, a history of mechanical fall, injury to the lumbar spine and pelvis, resulting in hip and pelvic pain. 9 months after injury, X-ray imaging demonstrated hypertrophic non-union of the right iliac wing fracture and displacement of pubic symphysis and right SI joint. I hope she was imaged before 9 months, but that's what they're reporting here. Maybe that's by the time she made it to the pain office. Pain in the lower back, which radiated to the right lateral aspect of the buttock, and groin and pelvic pain. She was unable to consider surgery, and her pain was not well managed with medications, thus she presented to the pain clinic. Patient underwent diagnostic obturator and femoral articular nerve branch injection. She also had a middle cluneal nerve steroid injection under fluoroscopic and ultrasound guidance, and reported improvement in her pain. She had a peripheral nerve stimulator trial and underwent implantation with leads in the right middle cluneal nerve and right obturator and femoral articular nerve branches. So the first thing I'm thinking is, this is the type of stuff I would offer. This is great. But then I'm thinking, they gave 3 PNS nerves. Well, it looks like it was a trial, but most devices will not give you more than 2 leads at once. So I'm just wondering what they did here. And anyway, the patient reported significant relief in both the posterior and anterior distribution of her pain. ADLs improved with PNS implantation, and now she's able to sleep. Through combined use of fluoroscopy and ultrasound, they were able to safely target the middle cluneal nerves and obturator and femoral articular nerve branches, and they could reliably replicate the patient's pain distribution with neurostimulation before permanently implanting the PNS, and the case demonstrates success in using PNS to treat the hip. This is a study I'm mentioning in my preliminary guidelines. Unfortunately, there's not much more. I'm going to keep looking. But if you have any studies that you can find on peripheral nerve stimulation for hip, I would love to read them. My search is not done, so maybe I'll find more. But this is something that I think it has potential. It's underutilized. I guess there's a few challenges here. One is the articular branches to the hip are deeper than, let's say, some of the other PNS targets we do, and there's a lot of movement at the hip. And then, of course, the groin is a place where infections can develop easier than perhaps, I don't know, the chest or the back or the knee. So there's a lot of considerations. Maybe that's why a permanent device might be the answer. But I just recently, in the last week, saw 2 patients who underwent diagnostic articular branch injections under ultrasound, not the classic articular and branches of the obturator femoral nerve. I'm talking about the PENG targets of the articular branches. And with respect to that, the first patient, he had a completely positive test, lidocaine in the PENG region, as well as the femoral cutaneous nerves alleviated his symptoms immediately, anterior and lateral, and he has residual. And then we brought him back and we did the cryoablation of these nerves. He is currently 30% better, and he has like numbness of the cutaneous nerve distributions on the anterior and lateral aspect of his leg, which he's happy about. He actually likes that numbness. But he has 30% pain, and it's actually medial and inferior to the hip joint. So I'm thinking obturator, possibly. Go ahead and do a diagnostic articular branch of the obturator, maybe under X-ray for possible supplemental RFA. But upon exam, I noted he had significant tenderness of the adductor muscles tendon. I don't know if it was adductor itself or possibly gracilis. I need to examine him again and use ultrasound. But I booked him for a diagnostic lidocaine injection of that tendon. Why am I not using steroids? Well, he's going for hip surgery in a month. He just wants symptomatic control until then. That's why we opted for the cryoablation on this patient. And I think if he does respond to this tendon injection, I may offer him PRP shot on the tendon. I have seen PRP work in as little as a week, but I've also seen it take 2 to 3 months to take. So I'm not really sure what I'm going to do with him. My other patient is a gentleman who had a hip replacement years ago, and he's had a chronic hip pain for the last year or so. And we did the PENG articular branch under ultrasound with just lidocaine, no steroid. He's 2 weeks out. He's completely pain-free from that one diagnostic block. And once again, I always say this just as an FYI. Anytime I do a diagnostic blockade with lidocaine 2% and compare it with another differential with bupivacaine 0.5%, that lidocaine 2% is usually the one that people say, wow, yeah, that shot was weeks ago, but I still feel better. Not really sure why yet. Maybe because it's just a more concentrated drug. But I'd be happy to hear your thoughts on this. Always feel free to email me. If you want to be on the podcast, I'm always willing to have guests. The problem is I podcast at I'm usually doing the show at 6 a.m., so it's kind of hard to get a guest at 6 a.m. Eastern Standard Time. But maybe if you're in Europe, you want to be on the show, I'm always looking for interesting people to talk to. I think the shows where I have guests are way more interesting. Lastly, yesterday, today's February 8th, so yesterday, February 7th, I did a lumbar sympathetic plexus block. Elderly woman with chronic postoperative knee pain after knee replacement. This is the second time I've seen this, where you do your geniculars and all your little nerve blocks and your ablations, and they don't get better. And then I wind up saying, you know what? Maybe there's some sort of causalgia component or a CRPS component to this, and I do a sympathetic plexus block. I've had patients where they fail everything. You do the block, and it works. And, I don't usually think of doing this first in elderly patients because CRPS tends to be more common in younger patients, usually women, fertile women. However, I've seen sympathetically mediated pain responsive to the blocks in the elderly, so don't forget about that. Anyway, I'm doing this block yesterday. I'm shooting contrast, and I see a pattern which almost looks like movement, kind of the way it's spreading, almost, I don't know, the first thing it reminds me of is a heart valve. Now, we're at L3, so there's no way I'm near a heart valve. And the contrast is not disappearing like it would if it was intravascular. So I didn't think I was intravascular. It was just an extremely odd pattern. And out of precaution, I readjusted my needle. I re-injected. But I took a video of this and I put it on my pain exam Instagram page. So if you're on my Instagram feed, check it out. Just look towards the top of the screen above my needle. I'm at L3 doing the shot. I think it's close to L2, L1 maybe. You'll see just a weird contrast movement of tissue. And what I believe that is just the contrast is spreading around another artery, possibly some sort of mesenteric or celiac, who knows, not the aorta. And it's just moving with the pulsations of the artery, not moving with really pulsations of the lung. There is other movement of her bowel you could see on this where it's really related to breathing, but this was more of an pulsatile movement consistent with her pulse. So either way, it probably would have helped her with her pain. It might have helped her if she had belly pain too, I guess. But either way, I was targeting her knee. She walked out of the office pain-free and safe. So it had a happy ending. We'll see how she feels in a week or two. Anyway, thank you so much for listening to the show. I really appreciate you guys listening to me ramble on for the last 15 minutes. Once again, check out the nrappain.org website, or just go to painexam.com. We also do anesthesia prep, PM&R prep, and monthly courses. My next course after this weekend's New York. Next weekend is going to be Miami, and it's my first Miami independent course, and I already have a good turnout, so I'm hoping to do a lot more. If you want to set up a course with a group of people in your location or come to New York, just hit me up. My email is drosenblum@rmcpain.com, or just reply to any of the emails on my newsletter. Thanks for listening. Please share the podcast and review it. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.